Hi, I'm Dr. Leah Giarratano, and I present a training program for mental health clinicians in treating traumatic stress disorders. You can complete this training via an international online learning package, which is self-paced, or via live stream where you're with a group of other clinicians completing it at the same time, or you can attend these programs live. So I'd like to tell you a little bit more about what's involved in this trauma training package. Just a little bit more about me. I'm an Australian clinical psychologist practicing since 1995, and I have expertise in the assessment and treatment of traumatic stress disorders. I'm a foundation team member of an award-winning inpatient program for treating post-traumatic stress disorder. I've trained thousands of mental health clinicians and GPs across Australia, New Zealand, and internationally via live presentations, online learning packages, and via live stream. I've been invited to present training for the Australian and New Zealand Defence Forces, for many corporate entities, in juvenile and adult mental health settings, and in community health settings. I'm the author of 7 psychological texts in the treatment of trauma and cognitive behavioural treatment, and also I've written 7 novels. If you're interested in more information about my background and my qualifications, please see talamanbooks.com. This trauma training series is highly practical and interactive. It's designed so that when you stop the training, you have immediately a large range of skills that you can apply to your clients the next day. All case presentations in the program are real-life de-identified clients that are used in order to explain how to use all of the tools. The first 2 days are dedicated to the treatment of post-traumatic stress disorder. The second 2 days are dedicated to the treatment of prolonged interpersonal trauma or complex PTSD. And there's a difference in the best practice management of PTSD and complex PTSD. Are you confident that you know the difference between these 2 presentations? Are you confident that you can provide best practice treatment for all of your traumatized clients? This 4-day training package will equip you with the skills needed to treat all of your traumatized clients. In addition to the 4 training days, you will be invited to 2 complimentary case study presentations. These are 2 hours each and they're completed after the training program. And I'll invite you to try to case formulate how you might approach the treatment with these clients in a structured way, using all of the tools from the trauma training series. And then I present a capstone presentation that illustrates how you can use all of the tools you learned in the 4-day training program for each of these cases. You receive the video presentation and detailed notes on how you can approach these cases using all of the skills in the 4-day training series. Altogether, if you complete all of the sections, including the program itself, the quizzes that are involved throughout the program, and also the case study groups consisting of 4 different cases, 2 PTSD and 2 CPTSD, you'll receive a total of 38 CPD hours. So days 1 to 2 are called Treating PTSD. In days 1 to 2, we'll be looking at how to treat people who've been going about ordinary lives and are confronted with calamitous events that leave them unable to get these experiences out of their mind. So we'll be working with people who've been the victim of terrible industrial accidents where they've witnessed someone being killed, or an awful motor vehicle accident where their passenger or the person driving them might have been killed, or combat veterans who've faced killing the enemy or witnessing enemy or civilians being killed, or our emergency services workers who've come across multiple traumatic incidents and now can't get them out of their mind, or somebody who's been the victim of a bank robbery or an armed assault. And these 2 days will focus upon best practice cognitive behavioural skills that have been shown to be effective in treating this trauma population. So we'll go through an introduction to post-traumatic stress disorder, comorbidity, the other conditions that go along with it, epidemiology, who gets it, who doesn't, do we know any resilience or any risk factors, the spectrum of traumatization and where complex PTSD fits in with respect to post-traumatic stress disorder. We'll also look at clinical assessment tools for making sense of the mess when your clients come in and kind of throw out all of this information about what they've been through. We'll look at motivation tips and treatment planning so that we know where to begin and how to motivate our clients to enter into therapy. The rest of the program is focused on practical, evidence-based tools for treating PTSD, including using prolonged exposure therapy to treat traumatic memories. and also how to restructure the irrational cognitions that go along with those traumatic memories. Negative cognitions related to the traumatic event itself. So things like, it's my fault, I'm weak, I deserved it. These cognitions are harder to shift unless you've brought down some of the distress associated with the memory itself. And we do that learning prolonged exposure therapy. The whole program comes with highly detailed instructive manuals that take you through all 4 days of the trauma training series. Just as an example of one of the models that we use that help explain PTSD to our clients, and also to help us know how to formulate a PTSD case, not a CPTSD, but a PTSD case, we can use this TRAP model, and it can be used to personalize the diagnosis of PTSD for the client. So it helps them to know that they went through a traumatic event, and that's the T in the TRAP model, which also goes along with criterion A in DSM-5. So if it was somebody who was driving to work with a colleague and their colleague was killed in a car accident and they survived the accident, then we'd say that that's where that fits in the TRAP model. And we'd say that since that accident, you've been stuck in this trap, and we have some strategies to help you get out of it. The R is for re-experiencing. This goes along with criterion B in DSM. And now you can't stop reliving this event. You keep hearing the sirens, you keep seeing the image of the person next to you who was killed. The A stands for avoidance. We'll avoid the memory of the event internally, but they also avoid a lot of external things, and that can cut them off a lot in life. This person might start avoiding driving on the highway where it happened. They might start avoiding driving in any traffic. Some of our clients will stop driving completely, and so their life becomes quite curtailed. They might find themselves feeling distant and cut off from other people, and that's the A column. It goes along with criterion C and D in DSM. And then the P column stands for physical tension or physical arousal, goes along with criterion E. And to make it personal for your client, you might say, this is the part of the trap where you find yourself getting angry and having outbursts of anger at people, where you can't concentrate, where you get startled really, really easily. So you can personalize it just using the parts of DSM that fit for your client. Then if we turn this into a treatment map, we start in the P column and we learn a basic functional analysis to help break down any crisis behaviours that the client might be presenting with. And people with PTSD will often have a crisis behaviour that compels them to come to therapy. It may be that they're drinking to try to block out the thoughts of what happened to them, and their partner says, if you don't stop drinking, you're out of here. Or they may be avoiding their workplace and their employer says, if you don't get back here, there's not going to be a position for you. Or they might be having so many anger outbursts that they've been sent to you by police. So we'll learn a basic functional analysis, how to learn what the function of that behaviour is, and how to help your client in a systematic way with that problem behaviour. And that gives your treatment face validity, because this is why the client often comes to see us when they have PTSD. We have a range of different psychoeducation models, including this TRAP model to help the client understand about PTSD. And then we have a whole group of arousal reduction exercises and anger management strategies that are practical and immediately applicable for PTSD clients. We then go into the A column and we learn in vivo exposure therapy or real life exposure therapy, best practice treatment for fears and phobias, and how to help our clients regain control and get back into their lives. And finally, we move into the R column, the symptoms that our clients hate the most, the re-experiencing symptoms, and we learn prolonged exposure therapy to help them process this traumatic memory, to help them organize and file it, to reduce or stop the re-experiencing symptoms that they dread so much and that they use a lot of avoidance strategies to try to block. And once we know how to do prolonged exposure therapy properly, we snap onto that, how to challenge those negative cognitions that are embedded or married to or fused with the traumatic memory, and how to help the clients see the other side of that. But it's not until we've reduced the emotional distress that we can actually access that more rational part of the brain and do this cognitive challenging. So after days 1 and 2 and learning best practice treatment for PTSD, we move to days 3 and 4, and that is treating complex post-traumatic stress disorder. Days 3 and 4 of the trauma training series are dedicated to treating complex post-traumatic stress disorder. People who have complex PTSD have been through prolonged and severe interpersonal trauma. These people have been traumatized by other human beings. You don't develop complex PTSD as a result of being through a terrible bushfire, although you may develop post-traumatic stress disorder. Complex PTSD, on the other hand, is caused by another human being. It erodes people's trust and faith in humanity and their ability to emotionally regulate. Complex PTSD is also sometimes called developmental trauma because it often occurs when the person was in early childhood or in adolescence, often during the attachment period and/or when the personality is developing. It is the case, though, that if an adult is subjected to enough prolonged interpersonal trauma, then it may erode any earned security that they developed as a child, and they may be left with a CPTSD presentation, for instance, with severe domestic violence, or somebody who's been the victim of a war-torn country over years, and it erodes their resilience, their sense of self, their ability to trust others, and their ability to trust their own emotions. Days 3 and 4, or treating complex PTSD, presents techniques that have been drawn from a wide variety of different clinical practices that are publishing in the field of traumatic stress and are having success with clients with complex PTSD and with borderline personality disorder. So we'll learn attachment-based treatments. We'll draw practical techniques from schema therapy, from emotion-focused therapy, from metacognitive and mentalization-based treatments, and some strategies from acceptance and commitment therapy, dialectical behavior therapy, and cognitive behavior therapy. The aims of these treatments are to help the clients develop an internal safe base, to also help them to learn how to mentalize, how to think about their thinking, which underpins the basis of emotion regulation, being able to think, what's happening for me right now? Why was I just triggered? What caused this? What can I do to calm myself down? And how can I use the outside world or my social relationships to try to settle myself down? And this ability to mentalize is a function of attachment. And often these clients were left neglected or severely abused when they were children, and they didn't have anybody to help them with these important developmental skills. Days 3 and 4 is aimed at treating complex PTSD clients who present with flashbacks, numbing and dissociation, emotional hurricanes or that real dysregulation of shooting up into panic, coming down into emotional shutdown, then going up again into suicidal depression, coming out of that in extreme anger and rage, and how to help them with those emotional hurricanes. This program also helps with somatization, self-hate, self-loathing, self-harming and suicidal acts, and also helps with skills to help clients with dysfunctional relationships, destructive relationships, and substance abuse problems. All of the strategies are practical. We have case examples and videos showing you how to use the treatments, and you get to practice the treatments. On day 3 of treating complex PTSD, we learn about the background of CPTSD and how that came about, how to differentiate it from other terms like attachment disorders, borderline personality disorder, developmental trauma disorder. So we look at the history of it and the concepts. There is a section on assessment, and there are some new tools out for assessing CPTSD. We look at an overview of the treatment approach using a phase-based treatment model recommended by the International Society of Traumatic Stress Studies in 2012. There's some controversy about whether the phase-based treatment model is too conservative and we should be moving into exposure-based interventions with complex clients as quickly as possible. We'll have a look at that controversy as well in the program. We'll be looking at psychoeducation models for CPTSD and how to help our clients understand how they develop the problems that they have. With complex PTSD clients, sometimes bombarding them with all of that information in the beginning can feel a bit invalidating. So one of the cool things about treating complex PTSD is that a lot of the treatment approaches are experiential and not so much didactic. Psychoeducation is important, but you'll be learning a lot of experiential tools that are working with these clients as well. A major focus of the program is helping the clients with emotion regulation. And as I said before, emotion regulation is a function of attachment. It's not just about arousal reduction and helping the clients with breathing and doing relaxation. Emotion regulation actually develops when we're in the attachment phase, where a concerned caregiver is constantly curious about the internal state of our mind. Even when we're pre-verbal, even when we're very, very young babies, the concerned parent is asking us, what's happening for you right now? What's going on? Why are you smiling? Or why are you frowning? Did you have a bad dream? Have you got a sore tummy? And this pattern goes on and on during our younger years, and we eventually begin to internalize that, to learn to self-reflect, to learn to think about thinking or to mentalize. And that ability to mentalize helps us to be able to realize when we've been triggered by something before it becomes a big explosion, understand the cause and effect of what might have happened to explain that, think about how we're going to manage our emotions and self-soothe, and then be able to repair any ruptures we've had in relationships when we might have been triggered, and also use those relationships to help us further our problem solving. So we'll be learning a whole variety of skills to help our clients with that. Our complex trauma clients are clients who will come to us, and some of them will say, "You're the best therapist I've ever seen. Nobody has ever understood me like you." And then you'll say something or do something and you might not even know what that was. And suddenly your client will say, "You're just like everybody else. You're going to let me down just like everybody else." These are clients who you will try certain skills with that you might use with other clients, and they'll say, "No, that doesn't work for me. No, I've tried that. No, that won't work for me." So they often have a feeling of helplessness and an external locus of control where it feels like nothing you do or nothing I do is going to change how I feel. And that's a feature of complex PTSD. So we'll be learning how the therapeutic relationship itself is an agent of change, how your relationship, your trusting, empathic, safe relationship with this client can actually make major life changes for this client, and how to actually use that relationship with the client to help meet the needs that they have when they come to therapy. We'll also be looking at day 3 at problem behaviors and establishing safety. Very often these clients are not safe. They may take any drug that they come across, drink as much alcohol as they possibly can, or they might continually find themselves in violent relationships, or leave a violent relationship and keep going back to the offender. They might get in people's cars that they don't know, or they might be self-harming and have suicidal impulses. So we'll be looking at practical strategies for that, for keeping our clients safe, and also to try to prevent transgenerational transmission of CPTSD to future generations. And then in day 4, we look at 2 approaches to treating attachment pathology, healing attachment wounds for our adolescent and adult clients in the here and now, knowing that attachment is a biological expectation from the cradle to the grave, and that our brains are capable of remapping and change. And these attachment-based treatments aim to activate the attachment need, which does create longing and a feeling of pain, but then to soothe that deep psychache that our complex PTSD clients have. So we'll be looking at some practical strategies to do that, including a really beautiful healing attachment-based treatment. We will then look at more tools for fostering metacognitive capacity. So that is about helping our clients to do that inward thinking, to think about my thinking, to understand when I've been triggered, to think about what's going on, to be able to look inside, to mentalize. So we'll be looking at treatment protocols that aim to do that from different kinds of clinical backgrounds. We'll also look at relational skills training or facilitating collaboration. Having a relationship is collaborative, and many of our clients, when they were young and during the attachment period, they didn't have anyone collaborating with them, helping them to understand verbal and non-verbal cues that are so important in helping other people to like us and to want to be around us. So the aim of this is to help your treatment effects go on after treatment ends, because you'll be helping your clients become more relatable to others by helping them with those skills. And then finally, in day 3 and 4, we move into phase 2 of phase-based treatment, and that involves the processing of traumatic memories. So in day 2, we spend almost half of the program in treating PTSD on learning prolonged exposure therapy. With treating PTSD clients, though, they may have only one massive traumatic experience, or in the case of a combat veteran, they might have 4 or 5. With a complex PTSD client, though, they may have hundreds of traumatic memories. So we will look at how to modify prolonged exposure thematically so that we can work with clients who have multiple traumatic memories and to help them to process those based upon themes that are interfering with their life. We'll also be looking at schema therapy re-scripting of traumatic and of non-traumatic memories, and we layer that up through the program so you get to see how that works with real clients. And we'll be also looking at an emotion-focused therapy technique called imaginal confrontation, which is a blend of exposure-based and gestalt-based therapies that help the client to process traumatic memories in an experiential manner. And there's also a section on self-care. We've been developing this training over 20 years, and we have, as I said, trained thousands of mental health clinicians in treating traumatic stress disorders. 2 years before COVID arrived, we were developing live stream and online training packages for people who wanted to attend our live training but were geographically unable to. You might prefer to do the self-paced online video package. If you prefer self-learning, you will still have access to all of the videos and all of the role plays that I do with clients that are presented in the live stream. Others like to do the live stream because they like to be involved with a group of other clinicians. They like to hear other clinicians' questions and answers. It's a very interactive workshop. So there are people from all over the world who are involved in that. Our live stream platforms are very dynamic and interactive, so you'll be able to talk with and meet with other clinicians as we go through cases so that we can apply the skills to those cases. And finally, after you've completed days 1 to 4, you'll be invited to participate in the trauma case study series, in which you'll receive 2 PTSD cases and 2 CPTSD cases, and you have the chance to be able to case formulate those cases, send them back to us, and we'll send you a capstone presentation which summarizes for you how to apply those treatment strategies that you've learned in days 1 to 4 to these 4 new cases. I hope this presentation has been helpful for you. I'd love to meet you at one of the workshops. If you want any further information, go to talamanbooks.com and you'll find a lot more information on the training series, on my background, and also on the books that we've published. Thanks for your time.